Good afternoon, everyone. I welcome you all for the fourth session of virtual online STG lecture series. Nowadays, chronic obstructive pulmonary disease is one of the major cause for the morbidity and mortality in the worldwide. Because of exposure to noxious particles, smoke, and pollutants, COPD cases are increasing day by day, as we are seeing now. Additionally, the pandemic COVID has made higher risk for the manifestation of respiratory disorders in the healthier people also. So today the session is brief about the importance of STG and diagnosing and treating of COPD challenges by the eminent speakers, Dr. Sangeeta Sharma and Dr. K.K. Chopra. I welcome you both for this session, ma'am, and I also welcome for the participants also. Now I request Dr. Jayan Srivastava, sir, advisor QPS NHSRC, to address the participants. Over to you, sir.
Thank you, Annapurna, and a very good afternoon to Professor Sangeeta Sharma, Professor Chopra, and all the colleagues from the states, from the central government institutions, facilities, and experts, and otherwise also those of you who are having the interest. At the outset, in fact, we are extremely grateful. Formal introduction will be done by Professor Sangeeta Sharma, of our eminent speaker today. But I know that in spite of your busy schedule, having so many competing priorities, we are, on behalf of NHSRC, we are really grateful to Professor Chopra for having taken time out of his schedule to talk to us on this relevant topic. Dr. Sangeeta Sharma has been the driving force behind this initiative since we started 4 months back. This is the fourth one today. And it gives an immense pleasure in knowing that over a period of time, people have not lost the interest and they really look forward to this lecture being held, because we realize more so that is where the personal interest of NHSRC lies, interest of the QPS division lies, that our endeavor is that the practitioners, service providers who are there in the field, they are able to refresh their knowledge. They know what are the recent developments, learn certain modern tools, and which goes a long way in improving the quality of care, besides improving the clinical quality, which is much ingrained within this endeavor. We all know that in the country, the longevity of life has increased. I will not go into those much of statistics, but in the broad sense, now the people are living longer. And once we know that if the people are living longer, there is bound to be certain deterioration in the body functions. In fact, just informally, I was talking to Professor Sangeeta Sharma that I had gone to Geneva for an important meeting on developing certain quality indices for life of care cycle approach. And one of the key things, first time now they have moved beyond the adolescent health. Now they are also talking about having the indicators for the aging population. The global body, they are becoming abreast, conscious, and come out with certain indicators. So in that context, like certain, the pulmonary functions will also deteriorate. And those of you who are from the program management side, and otherwise also may recall that though Professor Chopra will talk in detail, but chronic obstructive pulmonary diseases, which are one of the leading causes for the cor pulmonale. You may recall this term, which is the right-sided heart failure. And it is no longer limited to the smokers, like when I joined the medical college way back in 74, that time the traditional teaching was that COPD was limited to the smokers, those who are mine workers, prone to certain occupational hazards. Now, my young colleague, like Dr. Annapurna mentioned, that all over, all the districts in the country, they are having the very high level of presence of SPM, suspended particulate matter, in the environment. If you take out the time, it is no longer limited to Delhi. Even the smaller towns in the states of Bihar, Jharkhand, Uttar Pradesh, Chhattisgarh. I could not get the data from down south, but they are having the problem. And it is affecting the health. There are multiple effects. Besides the chemical pollutant, these particulate matters will affect our respiratory passage, which will affect the health all around. And we all know, and since I'm having a bit of sequelae of COVID, that how does COVID affects our respiratory passage. So in that context, this is a very timely topic. And once again, I'm extremely grateful to Delhi Society for Promotion of Rational Use of Drug. Dr. Sangeeta Sharma is honorary president of that organization, for spearheading this movement in the country so that all of us have the rational prescribing and our maximum number of the patients, beneficiaries, they will benefit. So in the end, I would request that kindly do participate in the quiz, because it helps us and it is a pointer for us that where do we stand. After all, this endeavor is a knowledge sharing platform. It is not a formal test, but we want to get a feel that where do we stand, and it helps us in planning a further course of action, that what training manuals, what standard treatment guidelines, what the clinical protocols, besides what diagnostic facilities the government is supposed to be strengthening, because NHSRC is a technical support institution with the Ministry of Health and Family Welfare, besides also providing the technical support to the states. So within that, do participate, do spread around the word. And Dr. Sangeeta Sharma has been very conscious of the fact that every time she comes out with the new topic, so you may hear that she is there, but always she will have something new product for you to learn upon, and we have also immensely benefited. With these words, I'm stopping over here, and once again, thank you very much, and extremely grateful to each of you. Thank you.
Thank you, sir, for acknowledging about the disease COPD and telling the objectives of this lecture series. So the next session is for prescribing practices for safe medicine use and role of standard treatment guidelines. I welcome Dr. Sangeeta Sharma, President, DSPRUD, and Professor and Head of Neuropsychopharmacology, IBAS. Over to you, ma'am.
Thank you, Dr. Srivastav, for setting the scene. I think it was very, apt, introduction to both the series. Why have we organized this kind of a series, online platform, for, connecting all over India, pan India. I don't think so. Had we planned for a face-to-face meeting, we could have ever achieved this number. So that way, I feel COVID is a blessing in disguise. It taught us, how can we extend these things to larger people, forums, and definitely, I take your words for this. There are so many aspects, dealing with the prescriptions, prescription safety, and what we write in the prescription, which are all very important, especially in today's context, when we have a very empowered patients are also there. They are also demanding, and then the medical legal, the requirements and the situation going on in the country. So we need to have, remain embraced with the latest and the proper requirements for when we write a prescription. And definitely the topics, we select topics where we feel that at the ground level there is a huge clinical variation. Especially COPD, I can share one experience. We were doing a statewide prescription audit in Uttaranchal, and we found that nandrolone injection was very used in high quantities. So then I started digging up, why is it that the nandrolone injection is being used in such high quantities. Then people told me that because this is a hilly area, people have this dyspnea and COPD, and they need nandrolone. Then I started getting into the detail, and I found that they did not diagnose COPD properly, and they were all mistreated, overtreated by use of injections. So that's the kind of sometimes we don't even imagine that this kind of a situation could be there at the ground level. All elderly, all in the name of COPD, or all in the name of weakness that they have, or they develop dyspnea over a period of time due to other illnesses. People get wrong treatment. So the idea of having these sessions is to just make us understand that knowingly or unknowingly some sort of variation happens in our prescribing, which may be harmful to our patient, which may unnecessarily add complications for our patients, or which may very often can add up to the cost of prescriptions. So today, in the first half, I'll be talking about how do you what goes wrong with the prescription, and what all steps need to be followed when you are writing a prescription, because all of you are supposed to do a prescription audit under NQAS scheme, but then at that time you are looking for what to look for in a prescription. Or the idea of this having this audit is to improve upon the prescription writing skills. So you would improve only when you know what's gone wrong with the prescription. So what are the different components of prescription, and how they can be misleading or can give rise to errors. That's what I'm going to talk about today. Let me share my screen now with you. Okay, before I go for my session, we had given you 10 questions. Let's have a quick discussion around this, so that you all get a feel of it, how it is important to remain updated, because some of these things, ours modern medicine is ever changing. There are therapeutic advances taking place every now and then, so we need to be keeping pace with those. First question was, if a person has an ischemic stroke, can you see my screen? Annapurna, can you confirm that you see this questionnaire here on my screen? Okay, fine, good.
It is visible.
Okay, good. Thank you. Okay, the first question was, if a person has an ischemic stroke, a door to treatment time should not exceed. The answers in green are the correct answers. The answers given in the gray are incorrect, because door to treatment time is very, very important for management of stroke patient. Ideally, the patient should reach the hospital for treatment as soon as possible. Ideal time is 60 minutes, but it has been observed that if patients arrive after 4.5 hours, there is not much of improvement. So if we want to our stroke patient to survive, so we need to really work on that. They should reach the hospital, they must get their MRI done. Before this, there are a lot of problems at the ground level. People don't have proper conveyance transport. Even those who have conveyance or transport for the patient, many of the time the person first contact doctor or anyone who sees this patient do not have any idea whether this patient is suffering from stroke and he needs to be expeditiously transported, referred to a higher level where he can be adequately treated. So try and maintain this time. Earlier it was 3 hours, but realizing the constraints at the ground level, now this has been made to 4.5 hours. But try to work on an ideal door to treatment time of 60 minutes here. Then second question was about chronic use of following medications has been most commonly associated with development of vitamin B12 deficiency. Except 30% of you have answered this correctly. Let me tell you, there are certain medicines which are given on chronic basis. Let's say 6 months or more. If you continue these medicines, vitamin B12 deficiency happens, and this is usually seen with ranitidine type of a drug or omeprazole, because they change the pH of the stomach and it interferes with the absorption of these medicines. Metformin, this why am I have added this question here, because most of us, I see that omeprazole, ranitidine, these kind of drugs are started, and the patient remains on these drugs for very long time, thinking that these are harmless medicines, but they have their own side effects too. So we need to be keeping those in mind. Similarly, metformin, diabetic patients, metformin is a very common drug used for diabetes patients, but on chronic therapy, as the duration increases, vitamin B12 so you deficiency happens. So we need to replace this, supplement this B12 for these group of patients. Then I have one question here. Key features of credible standard treatment guidelines include all except most of you have answered correctly. I'll be addressing these issues in my presentation. The idea of having standard treatment guideline is not to target all diseases. Idea is to target the priority diseases, the most common diseases that we see in our health facility. Very often, if you just start counting the type of or the different diseases that you see in your OPD, this may not vary, not more than 10, 15, 20 different types of diseases that you see. So you need to be knowing about these diseases very well, when you are sitting, because then you can cater to 80 to 90% of your patients properly. Then there is a question about patients with relatively small abscesses, smaller than 2 centimeter, with no symptoms or signs of systemic involvement, respond well to. Only around 30% of you have answered correctly. And this is a common myth that abscesses need to be treated with antibiotic, and that's where it is contributing to overuse of antimicrobial. Small abscesses can be effectively treated with incision and drainage and appropriate wound care. You don't need oral antibiotics. Very often we resort to using antibiotics as a shortcut, thinking that this will take care. Small, abscesses can be very well taken care by incision and drainage. Then there is a question about a 6-year-old male child who was found to be anemic during pre-anesthetic checkup, was given syrup tonopheron 1 TSF BD for 1 month. So the uh, Sorry. I think most of you have said first, ascertain the cause and severity of any should have been ascertained. Yes, this is correct. The choice of if the patient is having anemia, the choice of drug tonoferon is a iron preparation, is a right preparation. But if you look at the dose and duration of the treatment with tonoferon, keeping in mind the age of the patient, keeping in mind the weight of this patient would have been grossly overdosed, because tonoferon syrup tono, if you look at the strength of tonoferon, there are several iron preparations which are available in the market. They may vary from 75 milligram to 150 milligram of elemental iron. And if you look at the dosage requirement of iron, it is 3 to 5 milligram per kg body weight. And considering that this is a 6-year old child, although the weight is not mentioned, but the child would be around 15 to 16 kg weight only. And if you go by the dose of 3 to 5 milligram, not more than 90 milligram or 100 milligram of iron would be required for this patient. But if you look at the strength of tonoferon, iron in tonoferon, it is more than 250 milligram, and elemental iron is 150 milligram. And this patient was called given twice a day. That means this patient is getting overdosed, as it is the dose was not more than 90 milligram, was getting 150 milligram twice a day. So extra doses were given. And since this patient was called after 1 month, so this would have been, patient would have been overdosed for at least 1 month and would land up in toxicity. So that's where if you look at the root cause of it, why did this happen, why did the doctor overdose this patient? Because I think, to me it appears that the idea was, the doctor didn't have any idea what is the strength of iron in tonoferon. There are several dosage forms of a drug which are available in market, but we think that they are interchangeable, they are just the same, without knowing what are the exact strength. And then prescribing by one TSF, I will be talking about this in my presentation. Teaspoon, tablespoon, each one of us have a different size of a spoon at home, and it may vary from 2 ml 2 to 3 ml to 7 ml size of the spoon. So again, this is a variation. So all these things need to be kept in mind when you are writing a prescription. Now, then there is a question about drug-drug interaction. Can they lead to beneficial effect, toxicity, or lack of response? Many a times we write so many drugs for the patient without realizing that they may be having opposite effect. I'll give you an example here. A hypertensive patient who is also having osteoarthritis, a painkiller, diclofenac-like or brufen-like drug is prescribed to him. But the antihypertensive, the action is to lower the blood pressure, whereas NSAIDs, they increase the blood volume, fluid they lead to fluid retention in the body. So the action of both these drugs are opposite. So without realizing that, we keep giving these medications to these patients, and then we end up saying that these drugs are not being effective. So there are many different drug interactions which can take place. So we must keep that in mind when we are writing a prescription. I'll be talking about this drug interaction in my presentation. Then diarrhea is another condition where very often we use antibiotics. Very often, almost all patients with diarrhea, they are being given Norflox, Ornidazole, Norflox, ofloxacin, tinidazole. These वो एक prasad ki tarah we keep giving to all the patients who are presenting with diarrhea without appreciating that diarrhea very often 90% of the time is caused by the viruses, and no antibiotics work on viruses. We know that, but we are not able to apply this knowledge when it comes to practice. So there are only two indications for antibiotics. If the child has a bloody dysentery, that means shigellosis is there, and clinical presentation itself will tell you whether it is bacillary or watery viral diarrhea. And another indication is cholera. These are the only two indications where antibiotics need to be prescribed. Rest all are not valid indications. This add up to the overuse of these antibiotics, and which is leading to antimicrobial resistance. Now coming to the dispensing, especially in children, when we write a prescription for a child, very often a small quantity amount of drug is prescribed for small children, but very often we do not know what is the right way of measuring those. So that is why I had a question here: which of the following should be used to measure dose of 2.5 ml of liquid medication for children? Very few of you have correctly answered. The commercially available calibrated medication spoons, of course, are used for children, are also recommended. But here, if you look at carefully, the amount of the drug to be dispensed is 2.5 ml. The cups, the medication cups, they become inaccurate when the dose is less than 3 ml. So oral syringe is a better option, because then you can accurately measure these. So dropper is good for measuring 1 ml of a drug. More than that, it becomes inaccurate. Spoon, of course, as I told you, measuring spoons sizes may differ from household to household, so it can lead to underdose as well as overdose for a drug. So spoons anyway should be avoided for giving medications to children. Then there are two questions about key indicators indicating the diagnosis of COPD are dyspnea. Of course, you have correctly answered. Risk factors, those who are having these risk factors. Non-productive cough, yes, rightly you have said, because most of us think that productive cough, when it is there, then only it is COPD. But without productive cough, the patient may still have COPD. Dr. Kamal Chopra is with us. I think he will be. I'll not touch. I'm not the right person to answer to these questions. Similarly, then there are other statements here. I think you listen to him carefully to save on interest of time here. I will skip the discussion on these questions. Listen to him carefully, because all of these things would be addressed in his talk as well. And I'm very happy to see that around 60% of you say that mild exacerbations of COPD can respond to bronchodilators and inhaled steroids only, because otherwise the people have this notion that they have to give antibiotics for all exacerbations. So that's not the right way of doing it. And very happy to see that around 1/4 of you have answered this. Mucolytics have no proven benefit. Antitussives are not recommended. So I think the group is quite enlightened. So I can with this I can start with my presentation on prescribing safety. Sorry. Can you see my presentation? I hope these questions were you found it useful, and you could relate it to your common practice, that you see these kind of issues when you are writing. Can you spend a minute on this slide? I think it's worth reading this slide. This I had taken from Reader's Digest many years ago, but I find it relevant even today. Very often, if you've gone through the slide, very often it is we people, although our goal is to get patients well soon, and we don't have any bad intentions of harming the patient, but knowingly or unknowingly we end up harming the patient. So although it is on the humor side, but it is very much true. And we know that if you talk about patient safety, we are not supposed to cause any additional harm or risk of harm to the patient. We know that the patients come, death happens, there is a natural course of illness, complications may arise over a period of time, severity may increase. Those are part of the natural progression of the disease. But when it comes to patient was otherwise well, had come for some small procedure, and just because some harm happened, just because we did not take history properly, and the person suffers from allergic reaction or dies from a surgical allergic reaction, these are some things that are avoidable and need to be avoided when we are treating these patients. So there are several such examples. I'll take you through, what are those unsafe medication practices which can lead to errors and harm. And because the magnitude is so much, that the WHO has launched this challenge, and they said medication without harm. If you have seen this, the aim, in that they are trying to do is, and it is a global phenomena. It's not that we are seeing this in India only. It's a global issue right now that we are struggling with. The aim is to reduce this harm, and in alignment with this medication without harm, Government of India, Ministry of Health has also launched this National Patient Safety Implementation Framework in India. So, before I go further, let's see, where do these errors happen? If you look at this pie chart, 40% of the errors happen at the prescribing stage itself. Another nearly 40% happens at the stage of administering the drug. Something goes wrong with the administration. Then preparation of a drug. You wanted to prepare 1%, but you prepare 10% strength and administer, or you are not able to reconstitute it properly, or transcription errors may add up. 10 to 12% may add up. So, and who are the people who are at risk? Very small children and elderly people. These are the two groups of people, because they have different physiological processes at different stages. They are very, very susceptible to even small errors. And polypharmacy, last time I talked about polypharmacy. What do you mean by polypharmacy? When a patient, a single disease, otherwise healthy patient, if he gets more than 4 medicines for no reason, there are no comorbidities. If somebody gets more than 4, we call it as a polypharmacy. We know that the wrong drug, confusion of about look alike, sound alike, errors, all these contribute. And there are many high risk situations, high risk patients like elderly, children, patients with other diseases, liver, kidney, then high alert medicines. You all are aware of these things. Polypharmacy, because the more the number of the drugs that the patient is receiving, more are the chances that they will have some or the other adverse drug reaction, they'll have some or the other kind kind of drug interaction. And then those transition of care, patients who are shifting from one patient care area to another, from OT to ICU to ward, and from hospital to discharge. These are the points where mistakes happen. Duplication or omission of an important drug may happen. Besides that, there are, as I said, overuse. We are particularly interested in two classes of medicines: antibiotics and injections, where overuse, besides ADR and other things, can be harmful, not only for the patient but also for the communities, especially the antimicrobials. These are a group of drugs which do not only affect the individual but have community repercussions. You must have heard about antimicrobial resistance developing and patients not responding to usual first line antibiotics, simple antibiotics. They may need hospitalization or prolongation of hospitalization, and sometimes we are not even able to save patients. So that is why we are worried about antibiotics. Injections, of course, these are invasive methods, and then can give rise to additional problems of local infection, or they may transmit hepatitis B, HIV, AIDS, all those, if you unsafe injections are given. And also we are wrong medication, wrong patient, wrong dose. I gave you a scenario. Those were, the example I showed in quiz are real life examples, only that I had just put them in the form of a MCQ, but those were real life examples. During our medical education curriculum, undergraduate curriculum, if you remember, we were taught, choose a drug which can address 3 or 4 symptoms of the patient. So, but what is happening today is that most of our prescriptions are symptomatic prescriptions. We are trying to address these symptoms, rather than making a diagnosis for the patient, and select a drug. Very often I find that we are trying to address a symptom, so those are most likely symptomatic prescription. And uh, overuse, yes, we know that it's a big problem, but do we consider underuse also a problem? Is also a irrational use of drugs. It is equally harmful for the patient. When you need a medication and you don't prescribe, your patient needs it but we don't prescribe for various reasons. Asthma is something, I have seen. Diabetes, people delaying treatment, both at the patient's end and by the prescriber. That this patient needs hypoglycemic drugs or insulin, but this is delayed for several reasons. So that also constitutes irrational use of drugs. And of course, now drugs like loperamide are not used for acute diarrhea. But still, I find, this loperamide has been replaced with this prebiotics, probiotics, and other kind of drugs, which do not have much proven benefit, except, ORS, which is the mainstay of treatment. So, I think by now you have a good idea about how current prescribing practices are, and there is a huge variation in clinical practices. The underlying cause of this variation could be our, because we have been practicing like this, nobody has ever told us that what is wrong with our prescription, or we may be having some myth. We always talk about misbeliefs, myths of the patient, but more and more I interact, I realize that we as a healthcare provider, we as a doctor, prescribers, also have certain misbeliefs. For example, fever. Somehow we all believe that fever is a sign of infection, which is not true. Fever could be because of inflammation, fever could be because of other reasons. So any fever, a slightest rise in body temperature needs to be brought down with paracetamol, without realizing that the fever is a defense mechanism of the body, and some amount of rise in temperature is good for killing the germs faster, quicker, than fever is a defense mechanism. And we have this belief that fever, whenever there is a fever, we need to treat it with antibiotics, which is not true. And then there are gaps in the evidence based practice. The evidence does not support, for example, mucolytics or antitussives, or similarly, there are many other drugs that we keep using. Evidence may not support, but we still use, because we give this reason, oh, I have been using this, I've been writing this for many years. Combiflam is another example, a combination of paracetamol and ibuprofen. And during COVID times, this dolo became a real heroine. We all know the dose is 500 milligram. There is no such dose of 650 milligram. But now we have all switched to dolo. Earlier, when nimesulide was launched, people started writing nimesulide, and then it was realized, patients were being overdosed because the dose of nimesulide is very small, unlike paracetamol. So now we have started overdosing by using this dolo of 650. And also there is a huge concern about defensive practice, all in the name of medical legal implications. We think that by prescribing antibiotics or by asking for a battery of laboratory investigation, we are covered and will be saved in the court of law, which is not true. Evidence-based practice, defensive practice does not help. And of course, the trust, because of all these things, the trust factor that we had, the fiduciary relationship that we had with our patient is being destroyed over a period of time. And that's why we see a lot of violence cases. That is why we see a rise in court cases against the doctors, because of this mistrust. And we need to be worrying about medications, because I consider them as a double-edged swords. Do dhari talwar hai. If they have actions, they have side effects too. They can harm the patient. So we need to keep weighing, when do you use this, and which one do you use? I always give another example, if you can work with this needle, work with the needle. You don't have to take out knife or a sword every time that you want to manage your patient. So you need to choose these drugs properly. If you can manage with the needle, why not? Why a simple, cheap, effective drug which is safe also, for which you have enough evidence, for which you have enough knowledge of using the minimum dose, maximum dose, how to be used in other comorbid condition. Why not do it? But somehow we all land up in using most expensive one, the latest one, thinking that these are the latest is better, or the most expensive is the better. We have a lot of misbeliefs of these kinds. So medications, they need to be used very cautiously. While when you are using, there are two kinds of threats. One is that the patient may have side effects, adverse reactions. But as the nature of the drug is there, some most of often adverse drug reaction are not avoidable. They are not inevitable. You cannot avoid them, because it's the nature of the drug that it will give rise to that ADR. But whereas as far as errors are concerned, these are totally preventable. It is not necessary that the patient has to suffer from this harm because of these errors. This is totally preventable. So ADR, even for ADR, although people say that they are inevitable, but I say if the careful prescribers, careful providers can reduce this to a significant extent and reduce harm to the patient. So rational use of drugs require that kindly go through this definition with me. Each word of this definition is very, very important. It requires that the patients receive medicines appropriate to their clinical needs. When they need it, they get it. When they don't need it, they don't get it. If they need one medicine, they get it in doses that meet their own individual requirement. Here I mean, many a times we write children prescription for children, and we do not have appropriate dosage forms in our health facility. We think paracetamol hai, we can break it into 3 or 4 portions and meet the need for a child, which may be wrong, can be leading to overdose or underdose to the patient for an adequate period of time. If I need it for 1 week, I need it for 1 month, I need it for 6 months, the patient must get medicines for the entire period. It shouldn't happen, I've given half the treatment and I tell the patient to go and buy from market, and he is not able to afford and he does not complete his treatment. Again, it can lead to harm to the patient. And then last part of it, at the lowest cost to them and the community. Although in public sector, I saw most of the audience here today are from public sector, we may not be paying directly for this. We may not realize the cost implications of irrational drug use, but somebody is paying. Public sector, how do we get this is from all our tax paid money that we are getting running these. So any inefficiency in the system, we are directly or indirectly paying for it. Now there are many scenarios. How does this polypharmacy happen? How does we give a wrong medicine to a patient? Patient comes to you, says, you have prescribed something. The patient comes back saying that this is giving pain in my stomach, and very happily we are I can write another drug, because there are so many drugs available now. And I think it's not difficult for you to guess what would have been prescribed here. Take a moment and write in the chat box. Most often, I think it is omeprazole, antacid. Antacid pehle likhte the, it's out of fashion now. The primary drug here was a painkiller, and the second drug which was added is a omeprazole here. And problem is, even with single dose of NSAID, we want to give omeprazole, without having any evidence that these need to be treated. So, there are concerns about, I keep this slide, although at the cost of repetition here, but because the extent of use of omeprazole, like we are worried about antimicrobials, we are worried about injections, we need to be worrying about this PPIs, omeprazoles, pantoprazole type of drugs. Unfortunately, you may be writing these prescriptions for the patient, but particularly middle-aged or elderly patients who have gastric problems, once on these drugs, they remain on these drugs forever. And we don't bother because we think that these are harmless. No, they are not harmless. Again, I would like, if you can understand this, acid in the stomach is the body's defense mechanism. And without this acid in the stomach, you will not be able to absorb anything. You eat, you absorb things because of this acid. So it is for your protection. It protects you from infections. But by giving drugs like omeprazole, pantoprazole indefinitely, what we are trying is that we are altering the pH of the stomach forever. We are making it basic. So acidic environment is taken away. So this change in the pH of the stomach can give rise to so many other problems. So please, I would urge you to go back and see, if you can withdraw this omeprazole from your patients. You may get rebound hypersecretion of acid, but that's temporary phenomena. For painkillers, when you prescribe it, rather than focusing on asking the patient to take it after meals or have something, which can ease out stomach, we are straight away resorting to these drugs. So I already told you, any patients getting more than 6 medicines, think of some harm happening, some interaction happening to this patient, and all this happens because of a prescribing cascade. Patient comes to you with a problem, uh, you prescribe a drug, then there is a side effect with that drug, and to treat the side effect of this drug, you write another drug, and then yet another drugs, and that's how the prescription gets bigger and bigger. And one more thing, this prescribing cascade, one is because of the side effects, that you try to treat the symptom, provide the symptomatic relief, and you keep on adding. Second is, many a times when a patient comes to you, as the severity of the illness increases, you may have to escalate treatment, you may have to add another drug, step up therapy or escalation of therapy. But very often what happens is that we fail to de-escalate. We escalate it well, but we don't de-escalate. Very often it happens in case of asthma patient, that you upscale it, but but we don't de-escalate this. Something. Just sorry, there was some disturbance happening at the door. Then Okay, I think I can skip this. There are many factors. We have discussed some factors here. Of course, patients come and demand for it. They have some misconceptions. They try to rationalize economically. People don't want to fall sick even for a day. They can't afford to miss office, or daily wages are there. But I think today we can talk about the physician factors. I see that this patient demand, that they want drug or they are asking for antibiotic, this is more of a perceived pressure rather than the real pressure. We generalize these things. Some patients may be demanding, but not all of them. Some of them look upon you, that whatever best is for them, you will be writing those. And then fallibility is there because of we all make mistakes because of the inadequate knowledge. That's why we have a session today, so that if there is any gap in the knowledge, or keeping up to date, perhaps we can do it. And the last part, cognitive dissonance. Knowledge, we have the knowledge, but we don't act on it, fail to act on it. I give you example of diarrhea. We know it. We know common cold is viral. We know COVID is viral, does not need antibiotic, but still we treat it with antibiotics. So those are there. And sometimes we prescribe medicine just to keep the patient happy. If you talk to the patient, I'm quite fond of talking to the patients as well, as to why are they asking for so many medicines. They say, we take it because the doctor must have felt right for me. So again, generalization should not be there. Then there is a good amount of prescriptions which can raise drug interaction alerts. For example, if you look at this patient, this is an epileptic patient, had delivered 1 month back. This patient has been given oral contraceptive. This patient is already taking anti-epileptic drugs. Ferrous sulfate, yes, is required, but oral contraception was chosen as a family planning method, which is not the right method for this particular because of the potential for drug interaction of oral contraceptives with anti-epileptic. It may happen, this patient may have breakthrough seizures because of this interaction. This patient is also prone to have contraceptive failure because of this drug interaction. So when you write prescription, you must keep this in mind, that drug interaction could be one of the reason for failure of your response. So there are many drug duplication, wrong drug for that age, or high dose because or wrong drug is given in pregnancy. It can lead to harm. Now there are certain misconceptions also regarding prescription. People think when tablet is written, it means it has to be taken by oral route. Tablets can be administered by sublingual or rectal route as well. And similarly, when injection is written, it means that it has to be given IV only. It can be IV, it could be subcutaneous, it could be infusion. And another misconception that we write when we write prescription is that if strength of any dosage form is not written, that means there is only one dosage form available. No, it's not true. There are several dosage forms of a drug. A drug may have 5 or 6 or more dosage forms. So and it may be 5 milligram, 10 milligram, 20 milligram. So very good example is paracetamol. Different dosage forms will have different strengths. Iron preparations are another example. Different dosage. This thyroxine hormone, again you will find them in different dosage forms, strengths which are available. Insulin, different types of insulins are available. Not all of them are the same, and many a times SOS is written on the prescription. What do you mean by SOS? Very often we write SOS to for acute symptoms, paracetamol for example, SOS. What do you mean by that? How many times a day a patient can take paracetamol? A very simple drug that we use very often, every day. Almost every one patient who's coming up with fever, we write paracetamol, and we write SOS without knowing that what is the minimum interval, minimum gap between 2 doses of paracetamol. Can anyone write in the chat box? Yes, some of you have written correctly. 6 hours is the interval that should be there between 2 doses of paracetamol. But of course, if the fever is high and you need to lower down the temperature, you can repeat it after 4 hours, but not before that. So there is a dose, maximum dose prescribed for 24 hours. You need to follow that. Very good that you know about this. I think COVID is then and another thing which can make the prescription unsafe is the completion of the prescription, because I told you all these things, misconceptions and all that, these are usually taken care of. There are different parts of prescription in prescription audit guidelines. I think it's been covered there. So there are 4 and each portion of the prescription has its own importance. You can't say, the first one is important, or the only the drug name is important. No, all of them have their own importance. And then the way you write these prescriptions. Can you read this? How much is this? How many times a day LS6 has been written here? Write in the chat box. Okay, yes, QID, because you read it as QID. But in fact, that Lasix is not given 4 times a day. It was Q1D, which was read as QID. See, these abbreviations were for Greek, Latin abbreviations were there initially when these drugs were dispensed or compounded by the pharmacist. Today, we don't have any compounding being done, but still we are carrying on this legacy of Greek and Latin in our prescriptions. So, which can, this patient got Lasix for 4 times a day. So, whenever you want to give, once daily, write once daily. It hardly takes any time. Why, patients also do not understand. These prescriptions are for the patient, not for the pharmacist or anyone else. How many units of insulin this patient got? See, these are all again real life. 60 units, yes. One of you, 6 units, 60, 60, 60. Okay, so this patient got 60 units because this is for you, was read as 0 by this. It can be read as 4 also if the handwriting is bad. So, and the nurse who gave this insulin didn't have any idea what is the usual. 60 units is a very, very high dose of insulin. So, didn't have any idea patient got this 60 units. So, you always, when you have to write handwritten prescription, write UNIT. Don't write as U as a symbol here. Then, decimal place, where do we write this decimal? In this, I don't know whether you can see this, this prescription, it is a lamb, my own hospital, decimal 5 milligram. Now here 1.0 milligram is written. Here I don't even know whether there is a decimal. So again, the way you write decimal place is very important. It can lead to 10 times the higher dose being delivered to this patient, because you know how the prescriptions are kept. So there are certain rules about writing a decimal. Whenever you have to write 0.5, you write 0.5. You don't have a naked decimal here. Similarly, colchicine, for example, 1.0 milligram. There's no need to put this decimal here. Just write 1 milligram. Otherwise, it can be read as 10 milligram here. So, and always try to avoid writing in decimals. Write micrograms if you can. For example, thyroxine, it would be good if you write it in micrograms rather than 1.25 milligram of levothyroxine. Write 125 microgram. There are less chances of error. Now, abbreviations for drug name is very, very common. It has become a fashion now. People give all kinds of reason, why are they writing abbreviations, that shortage of time, heavy patient load, and all that. But basically, what the point I'm trying to convey here is these are non-standard abbreviation. These may be known in your own hospital, but others outside of your hospital may not be aware of. Today I don't have enough time to how orders like this can be misinterpreted and errors happen, and many times we use half names, cipro de dena, nitro de dena. And while we know, one of the session I told you there are thousands of preparations with similar names which are available, so you know that the potential for error is huge when you write a prescription, when you don't use standard abbreviations in your prescription. Then there are many other abbreviations that we use in our prescription, which can lead to error. So we need to be really, I gave you example of some of them. Even a simple error like, not having a space between the name of the drug and the dose can lead to overdose. Tegretol 300 milligram was written, this patient got 1300 milligram. Inderal 40 milligram was written like this, no space, patient got 140 milligram. So then we use abbreviations which are non-standard, people don't understand. So these can give rise to problems. So, and also another problem is that, CST. CST. What is CST? What is CST? Continue same treatment. Okay, very good. Can you tell me what do I continue here? This was the only prescription I had, the only page I had, with me. So very often, we get into this, routine of writing CST, 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 and we forget what is the original prescription. What is it that we are continuing? At least whenever a new prescription, new page is being used, card is being used, at least once a complete prescription should be written. The requirement is that every time you should write a new prescription. But if you cannot, write every time a new, at least on a new card, once it deserved to, a full prescription was deserved here. So don't write a repeat, then, very often we have instructions, take as directed, take or use as needed. What do you mean by that? No, these are very vague. For example, when I was in MCI, I was secretary MCI, was sitting in the ethics committee. This young boy got his leg amputated because of the tight, plaster which was applied. And then we looked at, whether the instructions was given to the patient how to take care of the plaster and when to come back. We noticed that there was just written as directed. Now the patient says that the doctor never informed me how what are the signs of gangrene. So we ignored it, and that's how the boy has to lose this leg. Similarly, very often we write ORS, how to make this ORS or how to take this, we says as directed. What is that direction? Now you will say, who has the time to write all these things in the prescription? I agree with you. Yes, there is not enough time to write this, but you can make small leaflets. You can, use as an addendum to your prescription so that the patient knows how to take this drug. So it is not vague. And then we can also write prescriptions, for oral dosage forms we can say take or give. For externally applied products we can write apply. We've seen patients, rectal preparations being taken orally because they don't know, it is meant for application. For suppository you can write insert, it hardly takes any time. It's just a matter of attitude that we need to be, addressing these issues. If we realize the importance, I'm sure you will address this also. So instructions need to be written properly. Then prescriptions, very often harm happens because of the allergy. Either we don't take this history of allergy, or if we take the history of allergy but we don't record it, at a uniform place. Some people write in the history, some in the treatment part, somewhere you will find in the nursing part. So make a uniform place, in the where you mention about this. And very often you also must be getting patients, when you ask them for a history of allergy, they say हाँ एलर्जी तो है, डॉक्टर ने बोला था कि कुछ कुछ ये वाली दवाई नहीं लेने हैं, but I don't remember the name of the medicine. So how is it going to help you? So now I think with mobile phone, everyone having this, and every mobile almost having this mobile camera. Either we can give a card, identification card, where we can mention the name of the drug to which the patient is allergic, or we can ask the patient to take a picture and show it to the doctor wherever they are visiting. So adequate and appropriate patient information is important. Then we see many of the children, right? So I think I told you already that don't use these spoons, don't use this needle wala, needleless syringe should be used. You can use cups, syringes, droppers, but for a smaller dosage you need to be using oral syringes, so that you can measure it correctly. And then counseling is often seen as the last attempt in catching errors that occur in prescription writing. But we fail. Then illegible prescriptions. We all take pride in that nobody can read my prescription, and we feel that the pharmacist can read this. But let me tell you, they are also guessing. अच्छा वो कहाँ पेट में दर्द है तो यही होगी, सिर में दर्द है तो यही वाली दवा होगी, अच्छा फलाना डॉक्टर ने लिखा है, उनकी तो यही फेवरेट ड्रग है. So they are also, so whenever in doubt, don't hesitate to check frequency. And I read this, a few days back, Lucknow, this is from news from Lucknow. The court has fined doctors rupees 5,000 for poor handwriting. So unless we take care of it, courts will intervene and, take care of it. So there is a huge cost. I will not go. One thing I would like to say here, that prescription is a medical legal document that it's not for the pharmacist, it is for the patient, so they need to understand this. So you have to look at, one is that you write correctly, then you write legibly, and you write complete prescription, so that there is. So anyway, one of the, I will I think it's already time. I will just briefly talk about the role of standard treatment guideline here. As I said, the first requirement of the prescription is that you write it correctly. How do you write? From where do you get this information? So you need proper knowledge about this. You need to be keeping up to date about these patients, why what prescribing is, what is a right drug for this, from where do you get this. uh, Guidelines are the time tested tools to promote rational use of drugs. It is advantages for the patients because it brings consistency amongst prescribers. There is no inappropriate variation. All of them get the right. Diarrhea, I mean, when I ask people, why are you not writing ORS, they say patients don't get satisfied. This happens because we keep writing, कोई antibiotic दे रहा है, कोई tinidazole दे रहा है, कोई IV fluid लगा रहा है. So because people then get confused, so supplies get better, and you would have the advantage that you get an expert consensus, up to date information about what is the best choice of drug or the treatment for a given patient. And you can concentrate more on the there are many other issues. STGs, they provide definitive directions, help you improving the supply chain. uh, but one thing is that they are disease oriented mini manuals, and they focus on treatment. Only thing, the starting point is that you must make a correct diagnosis here. But very often, we see that the diagnosis is not made. It's more of a symptomatic prescription. Some of you may be writing some symptoms, but very often we find that the diagnosis is not written. The legal, as regards the legal position, as the name says, it is a guideline. It is a voluntary this thing for you to follow this. It's not a law. But over the years, the situation has been that the courts have taken a stand. If you do not follow a standard treatment guideline, you must justify why haven't you followed a standard treatment guideline for this. You must justify. If you have no explanation, perhaps the court will give adverse orders on this. There may be issues of difference of opinion, degrees of skill, standard of care, but what is expected from a doctor is that you will have a general average person intelligence would be there, knowledge with. We don't expect genius people, doctors. We have people who exercise a optimum degree of care. So you should have, even this, you need to be monitoring adherence to treatment protocols. That also important for standardization of care. For example, I discussed with you the stroke care, and then reducing unnecessary prescriptions with antimicrobial opioids, PPIs, and saving life. So standard treatment guidelines is one of the ways to do it, because people with experts have developed this. They have looked at the evidence, they have sieved that, and after considering the available evidence only, they have selected treatment of choice for the management of a disease. We have this standard treatment guideline. We were the first one to bring this out in 2002. Ever since, we have been revising this. This is a ready reckoner type of a where we have discussed about treatment of priority diseases. Right now it is about 20 specialties, 330 diseases that have been covered, and it's quite up to date. A lot of people have contributed, reviewed this line by line, and we've been changing a recommendation in line with the existing. What is it that you look for in a standard treatment guideline? That you look for an introduction to the disease, and then salient features presenting signs and symptoms, which are diagnostics, and also the laboratory tests, diagnostics that need to be done, which are confirmatory. Like irrational use of medicine, there is a lot of irrational use of laboratory investigations as well. Many a times we get a test, ask for a test which is not recommended, which does not help us in making a diagnosis. So that's unnecessarily adding to the cost of prescription. So this salient features talks about which are the diagnostic ones, which can be done. Then the treatment part is very important. As I told you in that tonoferon example, anemia example, straight away the doctor went ahead with the iron supplement, but no non-pharmacological advice was given. Unless you give that, unless the diet or the nutrition of the child is improved, How are you going to treat this? You are not going to give this iron supplement indefinitely. You have a hypertension patient, but he takes a lot of salt. You have a diabetes patient, but the diet control is not there. So non-pharmacological treatment is important. Then pharmacological treatment, in this book we've given stepwise treatment right from the primary care to secondary level to tertiary care. Escalation step up is there. Very often step up is mixed with the combination therapy. I think today I don't have much time. Maybe in one of those sessions I can talk about this. And then patient education and references is given. All those things which are mentioned, recommendations which are given here, are backed by evidence and not by just any research article or a credible level A B kind of evidence. Wherever this kind of evidence is not available, we have given treatment based on consensus for this. I think I'll stop here. Patient education, yes, I think maybe I can spend a moment here on this. One of the uniqueness of the standard treatment guidelines that we have is patient education. Patient is an important partner. Many a times they don't adhere to treatment, or they don't complete, or they don't follow instruction, is because we haven't told them, we haven't given them enough instructions. And the problem I find is many doctors are struggling with it. One is because of the paucity of the time, heavy patient load. But even when they have a time, they don't know what to communicate to the patient, what all information should be passed on and what cannot be. So like that, they are not able to do it. I think I'll stop here. Now I invite Dr. Kamal Chopra is there. He's been patiently waiting for my session to be over. But I think I have set the scene for him. It would be easier for him to carry on this. Yes, Annapurna, can you introduce Dr. Chopra?
I'm sure. Good afternoon, sir.
Good afternoon. Good afternoon.
Dr. Kamal Chopra, Director, New Delhi TB Center, has 34 years of experience in the field of medicine and has published more than 150 articles on the various diseases. He was awarded for Charu Chanchal Das Memorial Award, PRJ Gandharam Endowment Oration, TB Association of Indian Oration Award, Dr. S. Satyadevam, Dr. S. John David Memorial Oration Award by the Andhra TB Association. Sir is also an associate executive editor for the Indian JF Tuberculosis and also a state TB training and demonstration center, Delhi. I welcome you, sir, for the session. Over to you, sir.
Thank you for the nice introduction, and thank you, Dr. Srivastava and Sangeeta ma'am, for inviting me for this session. First of all, your session was very interesting and very informative. I learned so many things in your session, and I hope our listener must have got an idea about the prescription errors and what are the rationales of different prescriptions. Ma'am, if you allow, should I start my session?
Yes,
sir.
yes. We're waiting to hear from you.
Thank you. This is regarding management of COPD, which is very common condition for general practitioner. As I know, most of our listeners are from the general practice. In general practice, we are getting many patients of COPD. Many times this diagnosis is missed, and many times there are some different errors in treatment. Treatment modalities have also been changing from time to time. There is a global initiative for chronic obstructive lung disease. Every year they release new guidelines, and this my presentation is based on 2023, which is the latest guideline which have been released about a month back. So I will be going through these guidelines which are of global strategy, and they are taken from the global initiative. First of all, it is a definition of COPD. There are many points in definition. I will try to make it simpler. All it is important that it is a heterogeneous lung disease. It is a heterogeneous means it presents in different forms. There are different complications and many times different ways of presentation. And one of the ways it is characterized by chronic respiratory symptoms, and respiratory symptoms are dyspnea, cough, sputum production, and exacerbation. So these are pulmonary respiratory symptoms. Second is due to abnormalities of the airways. So there is abnormality in lung tissue as well as the airways as well as the alveoli. So due to abnormalities of the airway, it is known as bronchitis or bronchiolitis based on the level where the disease is there. And if alveoli are involved, there is disruption of interalveolar wall leading to emphysema. We know what is emphysema. Second is it causes persistent, means symptoms and changes, they are persistent, often progressive if treatment is not initiated or preventive measures are not taken, or if the main risk factor we are not taking care of. And third is airflow obstruction. All this inflammation leads to more mucus production and leads to obstruction in the airway, which leads to characteristic symptom of dyspnea, which is progressive in this case. Very important point, it is written, it is a common, preventable and treatable disease. It is treatable and preventable also if we take preventive measures in the beginning, and it is a treatable with proper combination of drugs, and proper drugs are taken as per the severity of the disease. So this is a pictorial presentation of COPD. First is there is a persistent respiratory symptoms and airflow obstruction leading to dyspnea, cough, mucus production. Then there is airway or alveolar abnormalities. These are the airway abnormality leading to bronchitis. Then interalveolar septa are destroyed, lead to more air spaces, leading to emphysema, which decreases gas exchange. And third is smoking and significant exposure to noxious particle or gases. As it was highlighted in the introduction by Dr. Annapurna, that pollution, noxious gases exposure and smoking, they are the very common risk factors which are becoming more and more common nowadays, and more people are getting exposed to these risk factors. That is why there are more chances of developing COPD. So this is the difference which is showing in structural difference. This is a normal lung, it is a normal lung. This is the cut section of the bronchus. What happens in bronchitis? There is a hypertrophy of mucus glands. There is increased secretion which leads to obstruction of airway. This is the normal airway. In COPD this becomes lesser. Secondly, what happens in emphysema? Normal, these are the alveoli and this is the bronchus where gas exchange occurs, carbon dioxide is lost and oxygen is taken up. When there is a epiphysematous change, there is a lot of space but no septa, and in the septa there are blood vessels where exchange takes. So this leads to disruption of oxygen uptake and carbon dioxide being taken out from the body. It leads to breathlessness. And then definition, there are two stages. One is the chronic bronchitis and second is emphysema. Most of the times in adults, this is associated with chronic bronchitis and emphysema. We make the diagnosis. Bronchitis, clinically it is a condition where there is a presence of cough and sputum production for most days over 3 months for 2 years. This is a standard clinical definition based on which presumptive diagnosis of a patient of chronic bronchitis in our OPD without getting any investigation done. It says cough with presence of sputum production for most of the days over 3 months for 2 consecutive years. Based on this definition, most of the times we label clinically patient as chronic bronchitis. What happens in emphysema? There is restriction of air spaces, alveolar wall, it decreases the lung elastic recoil, enlargement of alveoli, and it reduces the maximum expiratory volume, and this is shown here. And this is the main cause leading to breathlessness. So regarding burden of COPD, it is estimated, this is the latest data which has been given in the DINA guidelines, that says there are 384 million cases of COPD worldwide, and most important is 3 million deaths that occurs because of the COPD, and COPD leading to many comorbidities and many problems or effect complications which we will discuss next. COPD is known to be the third leading cause of death globally. Globally as well as in India, COPD is the third leading cause of death. Most people with COPD will have an exacerbation. Exacerbation is very important. Whenever there is a patient who has developed COPD, from time to time there will be exacerbation. Exacerbation means there is some superadded infection leading to worsening of symptoms. And during exacerbation, we need excess of treatment, and these exacerbation leads to most of the time morbidity as well as the mortality in this case, with outcome following an exacerbation being poor. So if a COPD patient develops some exacerbation, then outcome is very poor, sometimes leading to death also. Lung functions are very important. With development of COPD, lung functions they decline accelerates. With the exacerbation, it is much fast, and there is a risk of cardiovascular complication, because whenever there is a COPD and emphysema, it leads to blood pressure and right ventricular pressure is increased, leading to condition known as pulmonary, where there can occur right heart failure also, and mortality rates are very high in COPD with exacerbation. This New England Journal of Medicine, they have given a chart that both globally in all the countries, COPD is increasing as per the year passes, and more commonly they have compared with China and India, and in India and China nowadays, India has overtaken China as far as the prevalence of COPD is increased. This is because of more urbanization in our country, more exposure to pollutants, more exposure to noxious gases and other factors leading to COPD. The burden of COPD, there is a relationship between comorbidity and COPD. Cardiovascular complications such as heart diseases, heart failure, which is most of the time it is right heart failure, and hypertension, these are the most important comorbidities. Other includes anxiety, depression, even leading to lung cancer, diabetes, osteoporosis. They may also play a role in the COPD and its development as well as in the exacerbation. In all patients with COPD, it is important that comorbidity should be evaluated, diagnosed and treated, because we cannot treat only COPD without taking care of comorbidity, which are leading to some serious effects in the symptomatology of COPD. So regarding taxonomy, there have been many classifications. This is the latest classification. COPD has been classified based on some etiology, like it is known as COPD-G when it is genetically determined. We know from the very beginning, since MBBS, we know there is a alpha-1 antitrypsin deficiency with other genetic variation, smaller effects acting as combination, and alpha-1 antitrypsin deficiency is the most common cause which had been associated with development of COPD, that is genetic, because of genetic mutation. COPD due to abnormal lung development. Sometimes there are early life events like premature birth or low birth weight among babies, and they can lead to COPD. Then it is known as, because it is because of lung development, it is known as COPD-12. Then most common is the environmental COPD, in which the commonest is the cigarette smoking, which is known as COPD-G. So that is exposure to tobacco smoke, including in utero. Even passive smoking in females, they can cause COPD-like changes in children in vitro also. So that is how much the damage that tobacco smoke is given. Not only active smoking, even the passive smoking can give the COPD changes, and that too, even if a female is pregnant, she can carry this smoke side effects to the fetus, and fetus can develop COPD changes. Even now, we newly developed like e-cigarettes. There are fashion of e-cigarette, and many people said they are less toxic or less dangerous, but even they cause the same effect. Biomass or pollution exposure is very common in village areas where biomass fuel is being used. That is the exposure to household pollution. This is known as the most common cause in rural area. Ambient air pollution, which is very common in metropolitan cities. Wildfire smoke is common in areas where there are frequent wildfires. Occupational hazards like that mining industries, etc. They also cause these type of things which are related to pollution. Then we label it as COPD. Just to explain the cause, then COPD could be because of infection when it is known as I. So recurrent infection in childhood, like TB associated with COPD, when TB is followed by COPD changes, then COPD with asthma, there is an overlap. There is a term used as COD, that is chronic bronchitis and asthma overlap. It is known as, then it is known as COPD-A. Could be COPD of unknown etiology, COPD-U. These are just a definition for defining the type of COPD, but most common remains environmental pollution or cigarette smoke related. That's the most common preventable cause. What are the clinical features for considering a cases of diagnosis? As I told you, we can presume a case of COPD on our clinical definition, where there is cough with production of sputum for most of the days in 3 months during last 2 years. Now this is our clinical definition, which has to be confirmed by the diagnosis with different investigation. So we should consider the diagnosis COPD, and most common and most important and confirmatory evidence is spirometry, where we do lung function test. If any of these clinical indications are there, these indicators are not diagnostic, but confirmation is by the spirometry. When dyspnea, that is progressive over time. In COPD, there is a breathlessness, and patient says with time, my degree of dyspnea is increasing. It increases with the exercise, and dyspnea is persistent also. And in later stages, in severe COPD, dyspnea is at rest also. So dyspnea is progressive, worsens with the activities or any rest, and it is a persistence. There is a recurrent wheeze. Recurrent wheeze, although it is common in the bronchial asthma, but can sometimes bronchial asthma can be coexisting with COPD. Whenever there is a option because of more bronchial wall thickening and because of secretion, it can lead to wheeze also. Chronic cough, which may be intermittent, may be unproductive. This was a question which we gave in your quiz pre-test also. Cough is usually unproductive with breathlessness, and sometimes it is productive also. But this is a common clinical feature in the initial. Recurrent lower respiratory infections, they are very common, and whenever there is an infection, it leads to exacerbation of COPD also. Then we should look for diagnosis. If there is any history of risk factor, we can ask the history of tobacco smoking, which is very common, and most common patients give history of tobacco smoking also. We take subjective history, like in the form of how many cigarettes they smoke per day, for how many years they are smoking, because the more the number of years, more will be the damage. Smoke from home cooking or heating fuels, very common in female patients, especially in the rural area. Then occupational dust in mining industries, vapors, fumes in different industrial areas. There are some host factors. Most common is genetic factor, which is alpha-1 antitrypsin deficiency, some development disorder, if the baby was premature or baby was underweight, or in childhood there have been recurrent respiratory infections. They also point out towards the COPD. So in these conditions, we presume COPD with the definition and confirm the diagnosis with the help of spirometry. Now we see what are the changes. Heterogeneous and underreporting of COPD. Many a times COPD is misdiagnosed as bronchial asthma or any other respiratory infection, and there is an underreporting leading to progression of the disease. So symptoms of COPD vary widely between the patient. So we should take clue from the different symptoms described. Most patients have breathlessness or are less active in order to avoid. This is very common phenomena in initial phase. Whenever patient feels breathlessness, he stops his activities. He doesn't take any exercise. He keeps on sitting so that to avoid, and he thinks that there is no symptom. But whenever he does any activity, he becomes breathlessness. Some but not all patients, they have got sputum production. It is common, and the frequency can vary considerably between the individual. It depends on the recurrent infection also and progression of disease. Patient may not report their COPD symptoms. This is important from the clinician to ask the patient about the symptom. If they get any clue of COPD, there are some thoracic changes in the chest wall also in later stages of the COPD. So if any clinician suspects COPD, they should ask direct questions related to symptom as well as risk factor, and most common are the exposure to dust, exposure to vapors, cigarette smoking, etc. Now, what are the other causes of chronic cough? The most common presentation to primary care provider is patient is coming with cough. Many times patient will say, I am having cough for so long duration. So we should know what are the common causes of cough so as to rule out other causes. So these are the different causes in addition to COPD which can cause chronic cough. They could be intrathoracic causes and extrathoracic causes. This table is very important to rule out any other cause of cough in a patient. Like asthma, it is very common, we can rule it out. Asthma usually starts in the childhood. Usually there is a history of some allergen. Usually during the night time patient sits up because of the breathlessness, and there may be history of treatment also. Lung cancer, in the initial stage it can cause cough, chronic cough. Tuberculosis, which is most common, whenever there is a cough, even our RNTCP or DOTS program that also says 2 weeks cough, it could presume to be tuberculosis, and we have to rule out tuberculosis. So this table is just to rule out other diagnoses of chronic cough. Bronchiectasis, it was very common in the past years because of recurrent chest infection. There was bronchiectatic changes leading to cough with foul smelling expectoration and breathlessness. Left heart failure, if there is a history of heart disease, if there is a history of hypertension for long and patient not taking treatment, it could be left heart disease which lead to chronic cough and breathlessness. Interstitial lung disease, it is also common, interstitial lung disease, and also can be misdiagnosed. So we should see whether there is any interstitial lung disease which can be ruled out on the physical examination or by spirometry. Cystic fibrosis, sometimes there is idiopathic cough also. Extrathoracic causes are common chronic allergic rhinitis, which is very common on the change of season. There is a rhinitis which is allergic to pollens or some cold weather. Post-nasal drip syndrome, it is very common in cases of sinusitis. Patient develops acute sinusitis, there is a post-nasal drip leading to chronic cough. Upper way cough obstruction syndrome, mostly viral at the changing season. Gastroesophageal reflux, this is very common and we usually miss it. Just ask the history of there is regurgitation or there is a acid reflux or patient gives history of gastritis. This is very important. Medication, this is most common medication is ACE inhibitors, which is most common used drug in hypertension, and it causes chronic cough. So these are some of the common causes leading to chronic cough which we have to rule out if we are presuming in a patient COPD change. Personalized diagnosis, if there is a patient of COPD suspect with that definition, first you rule out other causes by the history, and then we to confirm the diagnosis we should ask history whether these symptoms are persistent. Then we should ask the exposure to noxious particles like pollution or smoking. Individual risk factor could be from the birth, premature birth, or any changes or recurrent infection in the childhood. Clinical finding, we should see if there is any comorbidity related to COPD. Spirometry is our mainstay of diagnosis. It is required to establish the diagnosis, and in differential diagnosis all the conditions we have enumerated for the causes of cough, that is intrathoracic or extrathoracic. I think one of the participants has raised hand. Can they ask some question or is there a clarification required? Okay, we can take the questions in the end. Then identifying and assessing the COPD symptoms. Now for the COPD symptoms, we have to address the severity and the duration of symptoms. So whenever there is a patient gives symptoms of breathlessness, cough which are suggestive of COPD, we take history. In addition, there are different questionnaires. So different associations, medical associations have established different form of questionnaire. Based on the questionnaire, we ask the question to the patient or give a explanation to the patient, and based on the questionnaire, we diagnose COPD, diagnose as well as the severity of the COPD also. Then physiological testing, that is asthma. So there are different COPD questionnaire. These questionnaires are based on the dyspnea, which is very important, and use this is NMRC. That is classification. Then there is a CAT classification, CAT COPD. There is assessment could be based on the CCQ, SGRQ, CRQ. So these are different organizations based on the symptom criteria. They have developed certain questionnaires. I'll explain MMRC criteria, which is most commonly used because of the to assess the dyspnea. This is the questionnaire. We ask the patient to mark this. There are 4 grades of dyspnea, 0 to 4, based on the dyspnea. That is, grade 0 is that when patient says I only get breathlessness with strenuous exercise, this is common, this is not dyspnea, and we can rule out COPD in this case. Then grade 1, it is I get short of breath when hurrying on the level or walking uphill. So most importantly, patient will say I usually get breathlessness whenever he steps up on the hills or stairs, or he walks very fast on the level. Grade 2 is patient says that I walk slower than people of the same age on the level because of breathlessness. So in grade 2, person is breathlessness on level also on the same pace as compared to the patients of his own age. I stop for breath. Grade 3 is I stop for breath after walking about 100 meters or after a few minutes. That is important. That becomes grade 3, that he can on level he cannot walk much, not more than 100 meters. Grade 4 is when his person is breathlessness to leave the house, or he is breathlessness when dressing or undressing. So these are the personal works patient does. Even dressing and undressing time, he becomes breathless. That is the severest form of the dyspnea. So this is the type of grading where we diagnose COPD as well as we grade the COPD. This grading is very important not only for diagnosis, then to see the severity of the disease, and for the treatment also. Based on the severity, we modify the treatment with the response. This is CAT assessment. This is another form of to assess the COPD category, where it says I have cough and I have cough all the time and I never cough. So he has to grade from 0 to 5. So if there is no cough, he can say 0. Then I have got mucus, my chest gets tight. When I walk uphill, I'm not limited to doing any activity at home. So these are the different assessment tools which have been developed. Now for role of the spirometry in COPD, spirometry is first we diagnose spirometry based on the spirometry diagnosis of treatment. Then assessment of severity is also done based on the airflow obstruction. That is important for prognosis as well as for follow-up assessment. Like pharmacology in selected circumstances, when there is a discrepancy between spirometry and level of symptoms, so we base on the spirometry and modify the treatment. And sometimes we have to consider alternate diagnosis when symptoms are disproportionate to degree of airflow. So if the spirometry shows airflow obstruction, but symptoms are not that much, then we can think of any alternate diagnosis. Third is a non-pharmacological intervention may be required when patient is not responding based on the spirometry. This is the spirometry finding, which is very important. This is a normal curve where we show volume per liter, and here it is time in seconds. Forced vital capacity, which is normally is 5 liters in a person. So when patient takes deep breath and exhale, this is the curve which we get in normal. This curve shows that 5 liter air is exhaled on each breath after taking full breath, and up to 4 liters, that is 80% of air is exhaled in the first second. This figure we get FEV1 force expiratory volume of 4 liter or 80% is exhaled within 1 second. Forced vital capacity means total volume we exhale in each breath after taking deep breath, that is the 5 liter. So important is this ratio for diagnosis COPD. So FEV1/FVC, that is 0.8, that is a normal. What happens in a patient whenever there is an obstruction because of COPD or asthma? Forced vital capacity decreases, like in this example it is 1.8 liter instead of 4 liters. Forced vital capacity is also decreased, that is 3.2, it should have been 5. Whenever we are taking ratio, this ratio is 0.56. So if ratio is less than 8, based on this we diagnose COPD. This is the and based on this finding, we Gold has given the COPD grading. That is they say it is a staging. Gold stage 1, stage 2, stage 3, stage 4. Stage 1 is mild when FEV1, that is forced expiratory volume, in 1 second is more than 80% of the predicted. Predicted means we have got normal value in our country for male and female persons of different male and female of different age. So at a defined age, we have got a fixed predicted value of forced vital capacity, which is predicted for that age and that sex. If it is more than 80%, it's normal, or it is mild. It should be more than 80%. If it is between 50 to 80% of the predicted for that age, it is moderate. If it is less, more than 30, but it is less than 50, 30 to 50, it is severe. And if it is less than forced vital capacity, is less than 30 degree of predicted, very severe. Now, this spirometry also helps in differentiating from interstitials, where we get more of the residual volume in our chest after expiration. So, what is the Globe assessment? There are different assessment, same Gold classification which we are taking. Second assessment of the severity of disease is done based on the exacerbation. Exacerbation means there is exacerbation of symptoms. There are acute exacerbation of symptoms of COPD. If there are 2 or more exacerbation in a year, then we say it is E. It is a severest form of that disease. When, or there is only 1 exacerbation, but which led to the hospitalization. So in here, more than 2 exacerbation or 1 exacerbation leading to hospitalization, that is the severest form. And if it is 1 or more moderate exacerbation where hospitalization is not required, it is A or B. So personalized management of COPD. Now COPD, first we have to see initial assessment based on the symptom, smoking history, presence of comorbidity in that patient, and we do the staging. Gold staging is done. Initial management, because it is a preventable disease, we have to take initial measure, that is smoking cessation. That is very important. Whenever a patient of COPD stops smoking, with time, although it is not 100% improvement, but with years, the symptoms of COPD decreases. Vaccination, flu vaccination, pneumococcal vaccination, these are very important, because in old age or in COPD, there are common frequent viral infection that leads to acute exacerbation as well as increase the severity of disease. Initial pharmacotherapy. Pharmacotherapy means use of drugs either in the inhaler or oral form. If we start initially, we can control the symptoms. Non-pharmacological management is also important, that is to avoid risk factors. Self-management and education to the person, why he develops COPD, what are the causes which cause exacerbation, how to avoid, that's important. Last, management of comorbidity. If there is a comorbidity associated, that has to be managed for proper management of COPD. And during our management, we will review like symptoms, how many whether symptoms are decreasing or not, exacerbation, if there is an exacerbation, smoking status, whether patient has there are different methods for smoking cessation. There are different advices are given, there are different charts, and we have scales, and we can ask the how much cigarettes or bidi patient smokes. So smoking status is very important, whether he has quit smoking or not, or he has decreased. Inhaler technique and adherence. Now inhalers are the mainstay of treatment in COPD. But important is inhaler technique. Many times in our busy practice, we forget to tell patient how to take inhaler. And most of the time it is seen that inhalers are not taken properly. If not taken properly, drug doesn't go inside the chest and tissues to the alveolar level, and it doesn't make any effect. So inhaler technique is very important. At every visit, we should ask that patient, he should bring his inhaler, MDI or nebulizer, whatever it is, and we should see whether patient is taking properly or not. Need for oxygenation or non-interventional ventilation. Many times in severe condition, there is a requirement of oxygenation, vaccination, and comorbidities we have seen. And these, based on the symptoms, we have to review and adjust our pharmacological and other management. So at the time of diagnosis, we should see the symptoms, we should see risk factor, and we should see spirometry. Many times if there is a borderline levels, spirometry needs to be repeat also. Then in initial assessment, we have to grade like gold grading 1A, A to 4, AB grading A to E. And spiral exacerbation history, is there any history of exacerbation? Alpha-1 antitrypsin definition, smoking status. Initial management is done. Based on the initial management, we have to review, and based on the review, we have to adjust our pharmacotherapy or non-pharmacological therapy. The same as was in the previous slide, presented in different form. Now, goals of our treatment for stable COPD, we have to relieve the symptoms, we have to improve exercise tolerance of the patient and improve health status of the patient. Means we have to reduce all the symptom patient was facing, but more important than that, it is we have to reduce risk also. We have to prevent disease progression, that should stop, prevent and treat exacerbation, very important. Exacerbation can lead to morbidity as well as mortality also. We should prevent it by giving vaccinations or proper bronchodilators and educating the patient, and we have to reduce mortality by these measures. Now, identify and reduce factor exposure. Smoking cessation intervention should be actively pursued in all patients. This is very important. There is strong evidence that smoking cessation leads to improvement in COPD symptoms. Efficient ventilation, non-polluting cooking stoves, and similar intervention should be remembered. This is also strong evidence that if we stop exposure to polluting cooking smokes, it improves. Clinician should advise patient to avoid continued exposure to potential irritant if possible. There is evidence this advice should be given. So all these three should be taken care of on every visit patient presents to us. Regarding the therapy, there is therapy initiation. Initially, therapy should be with dual bronchodilator. These guidelines says dual bronchodilator should be given. There are bronchodilators which have been classified as SABA, that is a short-acting beta agonist, then long-acting beta agonist, short-acting anti-mucoscrenic agent, long-acting mucoscrenic agent, and third ICS, that is inhaled corticosteroid. These are the 5 types of drugs which are commonly used as basic pharmacotherapy for bronchodilation. Different combinations, individual, single therapy, dual therapy, or dual therapy with ICS. There are different indications, different time interval which these are recommended. And based on the patient response, we can change from double to single therapy, or there are indications where inhalation corticosteroids are to be started. So COPD, that is early LABA and LAMA. LABA means long-acting beta agonist. That is the mainstay of treatment, and long-acting antimuscarine agent. This combination is the bronchodilator of choice in COPD in initiation of treatment. So COPD is, first important is COPD is underdiagnosed. Many times we are taking to different diagnosis, we are missing this diagnosis. PCP or private care provider or peripheral care provider need to be alert to the possibility of COPD based on the symptom. Early diagnosis is important, as the greatest decline in lung function occurs early. If we start treatment at the earliest, so that will lead to decrease in the symptom as well as a stability of disease. There will be fast reduction in symptom and regression of the structural changes in the lungs. But it has been seen that more than 80% of COPD patients are at gold stage 2 or beyond when they are diagnosed. Only 20% patient, less than 20% patient, they are diagnosed as stage 1, where it is very important. If we diagnose at this stage, very easy to control the disease and very easy to decrease the structural changes, and patient will improve, and there will be less chances of exacerbation. Most of the patients are diagnosed, 50% are diagnosed as gold stage 2, and it may be patient is presenting late to us, or we are not suspecting this diagnosis, or 5% patient they present at the gold stage level 5, which is the severest form. So reduction in number of steps per day across disease severity. If patient responds, there will be reduction of steps, like at GOD 1, there will be 70% decline the patient can take steps at the level. By this, we can have a rough idea when patient is responding during our follow-up. So initial pharmacotherapy, if there is a group E is the severest form, which is characterized by more than 2 moderate exacerbation, means there are 2 exacerbation has occurred, and or there is one exacerbation which led to hospitalization. This is a serious form, and in this condition we should use LABA and LAMA. LABA, they are the artemetherol, like that is a formoterol which is available, and LAMA which is available as the glycet inhaler. And in this case, double combination is used initially, but if eosinophil count is more than 300, eosinophil count is more than 300 in the blood per ml of sputum, per ml of the blood, then inhaled corticosteroid should be. So we use triple therapy, double bronchodilator with inhaled corticosteroid. So these are the 3 drugs used. If there is a group A or group B, we can use only one. Like in group A, which is the mildest form of the disease, there is no exacerbation in that patient. Patient has got stable symptoms. Single bronchodilator like LABA can be used. If there is group B, that is the next form, combination of 2 could be used. Combination of 2 means when there is a MMR criteria or more, then we can use combination. If it is group E, then inhaled corticosteroid. So it's simple to remember. If it is group 1, that is 0 to 1 scale, single bronchodilator can be used. If it is group B, that is level more than 2, then LABA and LAMA combination. If it is group E, where there have been exacerbation, we can add inhaled corticosteroids. So this is the scheme of doing initial pharmacological intervention. So whenever we have started, we have to review symptom like dyspnea and exacerbation. We have to review and adjust, assess also. We should adjust inhaler technique. That is very important. Not only inhaler technique, but adherence should be there. If we have advised him to take inhaler 3 times a day, he should take. Sometimes patient, depending on requirement, patient may take once or twice. So technique as well as adherence is important. Then we should assess non-pharmacological approaches also, like patient's education, is rehabilitation, or patient should quit smoking. That should also be assessed at every visit. Based on our assessment with the symptom, we can adjust. We can escalate, either escalate or de-escalate. Escalate means we can increase the drugs from single therapy to double therapy or to triple therapy, or we can de-escalate if patient is responding from triple therapy to double therapy or single therapy. Or we can switch inhaler device or molecule. We can change the molecule also depending on the patient response. So timely double bronchodilation is important. It says that timely bronchodilation with LABA and LAMA has demonstrated several benefits versus monotherapy. If we are using monotherapy in stage 2 or 3, there are definite advantages that we should double therapy. The prevention of dyspnea and exacerbation when we use double therapy, and there is improvement in lung function and exercise capacity also. So except for stage 1 disease, we should use double bronchodilator therapy in the initial. So American Thoracic Society guidelines also says there should be double therapy in the initial stage. So benefits of dual bronchodilator therapy, it says there are different studies have been done. They say lung functions improve, health status also improve. This is based on the questionnaire, and dyspnea score also decreases. So there is a improvement in lung function, there is improvement of health status, and there is decrease in dyspnea index also whenever we are using double. So 2023 guidelines, they say double therapy to be used at the initiation of the treatment. So what could be the bronchodilator is stable. When we have controlled with double or triple therapy, then in the stable conditions, inhaled bronchodilator, we can use the only inhaled bronchodilator in stable therapy. Inhaled are preferred. They are central symptom management, commonly given on regular basis to prevent and reduce symptoms. There is strong evidence that inhaled bronchodilator for management of COPD in stable is important. There may be regular and as needed short-acting bronchodilator like salbutamol or terbutaline or SAMA like arformoterol or formoterol like ipratropium bromide. They can be used if short. There is also strong evidence. So whenever there is a acute symptoms, we can use short-acting beta agonist like terbutaline and salbutamol short-acting antimuscarinic, which are anticholinergic and inopropium bromide. These can be used, which improves FEV1 as well as symptoms. There is a strong evidence. And for letters stable, there is strong evidence we can use only inhaled bronchodilator. Combination of short-acting anticholinergic or beta agonistic, they are superior as compared to medication alone in improving. So there is strong evidence that combination improves the lung functions. Long-acting bronchodilators and anticholinergic agents, they improve lung function, dyspnea, lung health, and reduces the exacerbate. So these are used at the time of stable asthma, stable COPD. So inhaled corticosteroid therapy insulin, when and when not to consider it, there has been a misuse of corticosteroids, either inhaled or orally. There are certain indication of using steroids, either orally or inhaled, in certain condition at certain level of COPD. But many times it has been seen that they are used in the initial stage, where they are not helpful, rather they causes some complications. But we will see what these are. So ICSR, there have been different studies, proportion of patients receiving different treatment regimen in each of the gold stage. It has been seen that group D, there are different groups, the short-acting bronchodilators are used, on ICS inhalers are used. It has been seen that 83%, in 83% of the cases, all the three combinations, in different combination, including ICS, they have been used. Now, ICS or LABA should only be included in initial COPD therapy in patient. So this is the general instructions to be used, that only in group C we use LABA and LAMA with inhaled corticosteroid, in group B only one, and group B only 2 bronchodilators, no ICS. So ICS when is to be used? Whenever there is a 2 or more than 2 moderate exacerbation, that means stage E. Or if there is one exacerbation, leading to hospitalization. If there is a blood eosinophil count level of more than 300, or when there is a history of concomitant asthma also. Many patients, they have got overlap. There is a asthma as well as COPD. So these are the 4 conditions. 2 are the definition of stage E disease. One when the eosinophil count is more than 300, and another if there is history of concomitant asthma. These are only 4 indications where inhaled corticosteroid should be started. So this is a triple therapy. Gold recommends a triple therapy when these are the factors. Strong support in giving this is that if there is hospitalization, more than 2 exacerbation, there is concomitant bunsa. These are the conditions where we should strongly use ICSR. We can consider its use if there is one moderate exacerbation of COPD per year, we can consider. If there is blood eosinophils 100 to 300, we can. If there is more than 300, there is strong indication it should be used. If there is 100 to 300 eosinophils, we can consider. Again, when we should not use, if there is a repeated pneumonia events, if there is recurrent pneumonia is occurring because it reduces the resistance, there are chances of recurrent infection. If there is repeated pneumonia, we should not use it. If there is a blood eosinophil less than 100, we should not use it. If there is a history of mycobacterial tuberculosis infection, we should not use. So these are the 3 contraindications where inhaled corticosteroid should not be given. Other pharmacological treatments are alpha-1 antitrypsin therapy. It can be used whenever there is an evidence that patient has been diagnosed to have alpha-1 antitrypsin deficiency. Antitussive agents, many times in prescription, even Dr. Sangeeta ma'am said in question also, in his talk also, antitussives are used for asthma, where the patient presents with chronic cough. There is no conclusion of beneficial role of antitussive in people of COPD. There is no use, it should not be used, rather it should be avoided because it can lead to stagnation of secretion in the chest because they suppress the cough. Vasodilators, they do not improve the outcome and may worsen oxygenation. So vasodilators and antitussives, they should not be used in COPD. Non-pharmacological approach, there are 3 types. That first is the prevention, then non-pharmacological therapy, then instrument or surgical treatment. Smoking cessation is most common in prevention, then vaccination, influenza and pneumococcal. From age old, we are reading that these should be given. Now they say pertussis vaccine should also be given, and now for last 3 years even COVID-19 vaccine. So these are the vaccines which prevent viral infection in the person, and these viral infection can lead to exacerbation. Environmental exposure should be avoided. Patient should be said he should not get exposed to the pollution or gases. Non-pharmacological therapy, there is a rehabilitation by education and self-management, there is palliative and end of the care. If patient is later stage not improving, then palliative care can be given. Nutritional supplementation is also recommended. Then instrumental and surgical treatment, oxygen therapy is very important. Whenever there is end stage or stage 5, then oxygen therapy is required. Sometimes non-invasive ventilator support is required. Most of the time, whenever there is an acute exacerbation, interventional treatment are required. Now there are some discussion on lung transplantation also in sphere whenever there is a structural change. So even in last guideline, 2022 guideline, they also recommended non-pharmacological management of COPD also. Oxygen therapy in stable or whenever it is required. There is no evidence that long-term administration of oxygen increases survival in patients with strong, severe chronic resting arterial hypoxemia. So if patient is hypoxemic, even on rest, oxygen is required. There is strong evidence. Another strong evidence is patient with stable COPD and moderate or exercise-induced arterial desaturation. Prescription of long-term oxygenation does not lengthen. So in stable patient, we should not use it. There is strong evidence against using oxygen. And in severe stage, when there is at rest there is hypoxemia, we should use it. Resting oxygenation at sea level doesn't exclude development of severe hypoxemia when traveling by air. There should be care whenever a patient is not hypoxemic at rest, but if he travels by air and patient is of severe COPD, there is evidence he may require oxygen. Vaccination we have already discussed. Now we conclude what we have learned. What were the important factors? Now points we have discussed. First is COPD has a high disease burden. Disease burden is very common. Most patients will have an exacerbation which is associated with poor outcome. Many times patient presents at the time of exacerbation, and at that time he has been diagnosed that he is having COPD, and now he has come with the exacerbation. It is crucial to diagnose and COPD at any comorbidity as soon as possible. The moment COPD is diagnosed, treatment should be started because it is a chronic progressive disease leading to permanent changes in the lungs. The current evidence is for dual bronchodilator, which we have discussed. 2023 guidelines says that in the initial phase, except for stage 1 disease, we should start with dual bronchotherapy when starting COPD based on the evidence of its benefit over monotherapy. Caution is needed when ICS. Inhalers should only be added when there are 4 indications I have told you, and contraindication also. When it is strongly indicated, only then it should be added. Otherwise, there will be a risk of pneumonia. Patient with moderate to severe disease. Moderate to severe disease and a strong exacerbation history. There is a past history of exacerbation. They benefit from triple therapy. Triple therapy means double bronchodilator and inhaled corticosteroid. So if there is a moderate to severe, inhaled corticosteroid can be added. Lack of adherence to treatment is widespread. Patient doesn't adhere to treatment. The moment patient develops some improvement, he tends to discontinue the treatment and needs to be addressed. Technologically supported interventions are being developed. So at every visit, at least we should give them education to use the inhaler properly as well as regularly. The choice of inhaler is important, and poor technique and suboptimal peak expiratory flow can lead to worse outcome. Choice, we can choose MDI or nebulization. A personalized approach is needed for COPD management because every patient may have got some type of comorbidity. Every patient might be working in they might have got different occupation. So based on the patient history, based on the patient's risk factor, based on the patient's ability to continue with the treatment, so a separate individual treatment regimen with non-pharmacological approach has to be made for every patient. The main COPD symptoms are cough, sputum and breathlessness. They have got significant impact on lives of the patient. The moment these symptoms decrease, patient feels happy and he feels become important. But they are often unrecognized and underreported. Initially, patient usually ignores these type of symptoms. It's important for clinician to recognize and investigate these symptoms early in the disease. Early diagnosis depends on the capacity of our treating physician in the field to recognize this disease. Ask the right question and look at the patient's phenotype. So we should ask the question, the same question which have been given in the questionnaire also to diagnose or suspect COPD, they should be asked to the patient if we are suspecting it. This will allow each patient to receive the right treatment. The moment patient is appropriately diagnosed by spirometry, after suspicion, patient will be starting on appropriate treatment. Dual bronchodilation improves symptoms and lung function better than single bronchodilator, even in the new patient. So dual bronchodilation is superior to single bronchodilation in delaying disease progress. Dual therapy not only improves the symptom, it also delays the disease progression also, and even in all international guidelines, now dual bronchodilation is recommended. Inhaled corticosteroid can prevent further exacerbation in people with high eosinophil count. This is very important indicator to start inhaled corticosteroid when eosinophil count is more. Bronchodilator are the first and mainstay of the treatment. ICS can be added. Long-term use of ICS should not may lead to adverse events. So we should not use for prolonged period inhaled corticosteroid. Inhaled corticosteroid should be withdrawn in patients who no longer have got frequent exacerbation. Mortality benefits are similar with both double therapy or triple therapy. So inhaled corticosteroid are given only in the indication. Biomarkers may indicate risk in COPD. We should see all the biomarkers like alpha antitrypsin deficiency. Bronchodilator are first and the mainstay of treatment. Patients with frequent exacerbation benefit for ICS. And keep non-pharmacological intervention in mind. For patients with predominant emphysema, we can consider endobronchial interventions also. Diagnose and treat comorbidity whenever they happen. Thank you. This was all from my side. So if there are any observation or your experience, you can share with me.
Thank you, Dr. Chopra, for exhaustive view of COPD and making it easy, how to diagnose this and how to manage this appropriately. I think we can go through the questions in the chat box. The first question in the chat box was about if spirometry is not available, how do you diagnose this?
Yes, then it is based on the symptomatology, same symptom, and we can take help of questionnaires. MMRC questionnaire is very simple. We can ask when patient develops asthma, and we can stage also. So clinical diagnosis based on the history and some question asked, and we can see for the comorbidity, if there is any comorbidity related to that. So in field, we can presumptive diagnosis of COPD can be made. And after ruling out other causes of cough, that is very important. So 4 points are, first we have to see the complaints of the patient, severity based on the scoring method. Then third, rule out other causes of chronic cough. Intrathoracic and extrathoracic I given a list. So if we rule out other causes, if there is long duration of history and same age-old definition of cough for more than 3 months, consecutive for 2 years, cough with production, and examination, that can we can make clinical diagnosis.
Okay. Then there is a question about management of COPD in acute exacerbation. Can you elaborate on, when the patient is, I think this is one area whenever they have exacerbation, misuse of antibiotics also happen,
Yes.
How
do I forgot to tell, use of antibiotics. In stage 1, 2, 3, there is no use of antibiotics. There is either acute exacerbation or there is evidence of bacterial infection, which we can very easily see. If patient says sputum is colored like yellow or green, then there is a suspicion that patient has got suppurative bacterial infection. COPD is not a bacterial disease. So in stage 1, 2, 3, we do not require in a stable COPD case any antibiotics. Misuse of antibiotics will lead to resistance to the antibiotics being used. Most of the patients in stage 1 to 3 can be managed with the bronchodilator or inhaled corticosteroid. That's one point. Antibiotics may be needed in acute exacerbation. Now, how to manage acute exacerbation? For peripheral field doctors, acute exacerbation is indication of referring to higher center. Whenever there is a diagnostic problem, or if you are suspecting that is a acute exacerbation in a patient of COPD, you should please refer this patient to a higher center, because acute exacerbation requires heavy antibiotics, proper bronchodilator therapy, many times require oxygen also, and different investigations also, and steroid also. So the most important work whenever we are suspecting acute exacerbation is to refer the patient to a higher center. In higher center, triple therapy is given with long-acting bronchodilator, antimuscarinic, anticholinergic agents, steroid, which may be inhaled corticosteroid, oxygen therapy, and if there is any comorbidity, which is managed. Course of antibiotics is also given whenever there is acute exacerbation, because most of the time acute exacerbation occur because of the bacterial, superadded bacterial infection.
So when do we use nebulizers? Generally.
Yes. There are three methods to give inhale this bronchodilators. That is MDI, metered dose inhalers. Then there are different devices with powder form and it is inhaled. And third is the nebulization. Nebulization in that vapors come with the pressure. So whenever there is a acute condition or patient in the initial stage, nebulization should be used, because of the high pressure generated that goes inside the chest and gives relief. Second thing is, whenever the MDI is given, metered dose inhaler, it is very difficult to train the patients in initial stage, because he has to press the trigger as well as he should start inhaling. Only then the drug will go inside the chest, otherwise it remains in the throat. So in the initial stage, when patient is presenting or symptoms are severe, I think nebulization should be the best.
Okay, then there is a question about the vaccination. Somebody has mentioned zoster, herpes zoster, shingles vaccine. Is this also recommended? And what about government facilities? Are they available in the program, or these are additional vaccinations?
Pneumococcal vaccine is available and it is recommended also. Influenza vaccine is also recommended, especially in old age group, to prevent acute exacerbation. Third, COVID-19 vaccination is also available. It is now freely available. And the fourth, DTaP vaccination also given. But I am not sure about the herpes zoster. Shingle vaccine is not given in the COPD patient. So in COPD, we give pneumococcal, COVID, influenza, and nowadays to avoid pertussis, DTaP vaccination is given.
I think there is a question about indications for oral steroids in COPD. You've answered this. Maybe you can once again.
Oral steroids as such are indicated when there is acute exacerbation or severe form of disease. Then if patient is not responding to inhaled, oral steroids can be given only in acute exacerbation, severe form of disease, or whenever there is a eosinophil count is increased. And fourth indication I told, that was because of the if there is a concomitant asthma. So whenever you're not responding, we can add oral steroid also in acute stage.
What should be the duration of treatment with oral steroids?
In oral steroid, duration should be minimum. It is started with a minimum dose. Based on the response, dose can be increased or decreased. And in acute exacerbation, within 2 to 6 weeks, within 2 weeks, patient usually responds, and within 6 weeks, the dose is tapered. Not more than that is required.
Okay. Tapering is usually required whenever there is a
there is more than 2 weeks, it is required.
Less than 2 weeks duration?
It can be stopped at once.
Okay. I think this is another area where people, have a difference of opinion. Short-term oral steroids do not require tapering. You can stop them, but of course, if they are continued for more than 2 weeks, then you have to slowly taper. And the dose is 1 milli. How much is the dose?
0.5 to 1 milligram per kg body weight.
Okay. Then role of yoga, pranayam. I think it's to do with the prevention and the building capacity.
In both, in prevention as well as in building capacity. All these exercises, these are the respiratory exercises which should be taken. They are helpful.
Are there any other questions? I think we have dealt with all of them. What is FBI? I think somebody has written nebulization and FBI. What is FBI? I don't.
FBI, this is a different type of device to give inhalation therapy.
Okay. Are there any other questions? If there are, okay, azithromycin, role of low dose azithromycin in COPD.
No role of antibiotics in lower dose in stable COPD, only in acute exacerbation if there is superadded pneumonia or there is a fever or if there is a purulent expectoration, only then it is indicated. Otherwise, low dose of antibiotic not required either for prevention or for the stable COPD case.
I think many a times people take yellow sputum as a proxy. But I think yellow sputum could be because of the WBC. That doesn't mean that it is bacterial.
Yes, you're right, ma'am.
So, which is the drug of choice in case antibiotic is indicated?
Erythromycin or azithromycin, both can be used. In my cases, if it is very severe, then intravenous antibiotics can be used.
Okay. I think we have dealt with all the questions. Regarding the recording, you are asking for the presentations. YouTube recording will be available after a week or so. I think Annapurna will circulate that information to you all. Right now, we have put a post-test link in the chat box. Kindly finish this. This is one of the requirement to get the certificate. There is one, meanwhile, while people are filling up this post-test, somebody has asked about magnesium sulfate, role of magnesium sulfate in COPD.
No, it is not recommended in our guidelines.
Okay. Then there is also a question about role of moxifloxacin. Should it not be limited, restricted because the, respiratory?
It should be restricted for ear infection, and nowadays we are using for tuberculosis also.
Because this is one of the drug for MDR TB.
For MDR TB, yes, it should not be used as routine antibiotic.
Yeah, because if we use it, if we use this regularly, then resistance will develop to this mox. So TB, we will not have any, good treatment available for us. Annapurna, you can also put the feedback form in the chat box. I take this opportunity to thank Dr. Kamal Chopra for readily accepting for this session, and I think he has done a commendable job of putting all aspects of management of COPD together in brief, and making it simple for all the we have a very diverse group of audience here, and I think all of us got benefited, understood the problem, how it can be managed. I think further, if anyone has missed anything, YouTube recording would be available. You can go through this. You can use this for further, education in your own hospital or other, wherever you feel like. I think with this, we thank Dr. Kamal Chopra, and we look forward, for future more such topic in future as well.
Okay, ma'am. Thank you. Even on behalf of NHSRC, I thank to Dr. Kamal Chopra sir and Dr. Sangeeta Sharma and all the participants for attending this session and make it a successful. Even I also thank to Dr. Jain Srivastav sir for supporting us to conduct the regular sessions without any problems or interventions. And attempt of the pre and post test is mandatory to get the participation certificate for all the participants. I have seen that many are attended pre-test and they forget to attend the post-test, and some are not attended the pre and most of them are attended the post-test. Please go with the pre and post-test both, then only you get the certificate for the participation. Later we get the so many mails that we are not getting the certificate. As it is an automated generated certificate who has attended pre and post, it will automatically, the names will be go to the IT team. They are going to send from the their end. So please attend both tests to get the certificate. And recording of this session will be available in quality and patient safety division of the YouTube channel. There you can access it, which I have shared the link in the chat box. Through that, after 3 to 4 days, this session will be uploaded in the YouTube channel. So please go and access there after 3 to 4 days. By Tuesday or Wednesday, you may get that. And the next session is on January 21st regarding the diabetes mellitus, type 2 diabetes mellitus. Soonly we will send the link for that also for the next session. And feedback form is also has given in the chat box. Please give the reply for the feedback also. And the STG session, STG of the NHSRC also has the 12 standard treatment guidelines, which you can access through the link which I am sharing in the WhatsApp now, the chat box now. So please go with that. Some of the standard treatment guidelines prepared from the NHSRC is also there in that. Through the website, you can access it. Thank you, sir. Thank you, ma'am, for the fruitful sessions. I hope all the participants have got the benefit of this session over the COPD and the importance of prescribing the drugs and the standard treatment guidelines.
Annapurna, I didn't see the feedback link in the chat box. Can you
I
just...
have shared. I'll share one more time.
Yeah, please do that. I must thank Annapurna also. You know, it's a holiday for them.
That's okay, ma'am. Even yeah, in a holiday also attending the session is also gives more knowledge on even as a participant. Even I also attend all the pre and post tests to know that what is the correct answer actually. It becomes
Okay.
helpful for me to even as a practicer. I need to know some of these basic problems or the indication where we are going to do a wrong while prescribing the drugs. Even it is helpful, sir. Helpful, ma'am. Thank you.
Yeah, and I must thank the participants equally. Although we planned for 2 hour session and are almost it's more than 2.5 hours, and you still stay on for the session and remain active and keep asking questions. That gives us the energy, motivation to organize such programs. Online sessions have their own limitation, but I think it has more advantages now that we can feel that we can reach out to more people and have more such activity. Thank you to all of you, and see you next month, January 21st, for the pearls on diabetes management. This is another very important topic because India has become the capital of diabetes patients. Earlier, it was thought that it is the urban problem or problem of elite, but now people from all sectors are also suffering from diabetes. So we need to be very careful about this. Thank you all. I think with this, can I, the link is there for the posters. You can complete this. Or, I think we have got only 114 responses so far, and we have around 200 people in the room even to now.
Certificate you will get through the mail ID which you have registered in the during the registration form.
Yeah, this is another problem. Sometimes we give some other email ID and we look for it in the other. You may have having 2 or more email IDs. So please remember which email ID did you use, and also look for it in your spam folder. Sometimes lands in your spam folder में भी चला जाता है, जंक मेल में भी चला जाता है, तो आप उसको भी देख लो एक बार अगर वहां पर आया होगा, क्योंकि ऑटो जनरेटेड है तो ऐसा होगा नहीं कि आपको नहीं मिलेगा। हाँ, एक प्रॉब्लम हो सकती है कि प्री और पोस्ट दोनों रिक्वायरमेंट्स फुलफिल हुई हैं कि नहीं हुई हैं। Post test link, I think we have put this here.
Yes, link submitted, ma'am.
No, somebody's writing.
Not received certificate. If you are not attended pre and post test, you won't get the certificate, sir. If you have any query, please mail to stg.webinar@nhsrcindia.org.
You can write this email ID in the chat box.
Sure. Thank you for the participants. Thank you, ma'am. Thank you so much.
Pre-test link, you will not be able to fill up pre-test. Now you have to do the post-test link. Don't attempt for the pre-test link. वो I have stopped उसमें accepting responses, क्योंकि वो तो प्री सेशन था ना, अभी आपको पोस्ट सेशन करना है।
Thank you, ma'am.
Okay, thank you.
Now, thank you all the participants. We'll meet in 21st January 2:30. Thank you.
Yeah. So till then, stay
healthy, stay safe.
Happy New Year to all of you.
Yeah, Happy New Year to all. Happy New Year to you, ma'am. Thank you. सेव करो, एंड करो।